Well, good morning, everybody. Happy New Year. It's my pleasure to welcome you back to Grand Rounds for 2020. And as promised, we're starting with a prostate lecture. I hope you're all excited. I know I am because we have Dr. Nicholas Boncher here with us. He has recently joined Providence in the Plaza building here, and he's been an exceptional urologist for our primary care clinic. Very pleased to have him here to talk about prostate enlargement. Dr. Boncher received his medical degree from the University of Michigan and then did residency at Case Western in Cleveland, followed by a fellowship at the Cleveland Clinic in male reconstruction and prosthetics. He was formerly the director of reconstructive urology at the University of New Mexico, and as well as a reconstructive urologist at the VA in Albuquerque before coming to Portland. He and his team represent one of two centers of excellence in the Pacific Northwest for the UROLIFT procedure. Dr. Boncher specializes in BPH and as well as other urologic procedures and pathology, and we're very pleased to have him with us. Welcome, Dr. Boncher.
Thank you. Can you guys hear okay? Okay, I'll walk around. As we were talking about, it's more of my own nervous energy, more than any ploy to keep you guys involved. We're going to talk about BPH, but it's also entitled BPH and Men's Health. Actually, I think I have to turn this off. There's going to be some feedback. Okay. Because I do want to make a couple of plugs in here just about some of the other things that I think are important and are sort of changing in the urological landscape. You mentioned, thank you very much, about where I came from. I graduated from the University of Michigan. We've had some rough football years, but our basketball team is not so bad. And then I went to Cleveland to Case Western, and then literally across the block to Cleveland Clinic. It's sort of this unique, aggressive competition between those two institutions, and they're literally next door to each other. I did grow up in Michigan. I don't live there now for some great reasons. But if you haven't visited Michigan, I think it's a great place to go visit, only in the summer. There's a couple of cool pictures. This is called the Pictured Rocks National Lakeshore. This is on the southern coast of Lake Superior, or sort of the northern edge of the lower peninsula. And it's amazing. It's beautiful. This is Grand Haven Pier. This is about 45 minutes outside of my small hometown. And this is where we'd go in the summer if we got out of school early or want to go to the beach. And this is sort of what that looks like. Lake Michigan is not small. It's 50 plus miles across. It's several hundred feet deep. They have big storms. They have big boats. It is a lot of fun. There's no salt in the water. There's no sharks. It's a great place to vacation. But as you'll notice, it's a summer-only place to go. So this is that same pier in winter. And you can imagine what this looks like if this sort of starts early in December and ends in April. One year in Cleveland when we were living there, I remember, because it was April 20th and we got 20 inches of snow. So I'm here in Oregon for lots of reasons, but this is maybe one of the biggest ones. I don't have to scrape my car, which is great. Men's health is sort of a new-ish term. It's something that we talk about at our national committees. There are sort of subcommittees about men's health. And sort of, what is it? Well, it's this sort of broad term. It's ambiguous. It's sort of like a buzzword. But when we think about looking across like the landscape of hospital or primary care or other subspecialties, we see we've got a place for kids, we've got pediatrics, we've got a place for the elderly, we've got geriatrics, we've got women's health. Okay, we have all these sort of designations specifically for everyone except for men. And men have sort of been not left out in the cold, but sort of a lot of the issues we've had have been ignored. And fortunately, many of those issues come across the urological landscape. But I think what we have done, as we've done in so many parts of medicine, is we've only focused on disease. We've only seen people when they have a problem. We haven't looked at them and said, hey, you're 52, I know you're here for blood in your urine, but let me talk to you about these other issues which you might start to experience in the next couple of years. What are those? What can you expect? What does that mean to you? And so really what it is we want to look at those things that sort of historically we have identified as manly things, the things that we all intrinsically sort of know are the essence of us. And a lot of things are, unfortunately, things that patients don't like to talk about because they're men, and that's sort of part of the overly generalized sort of thought process of being a male, but it is in reality often true, as we know. Lots of men don't like to talk about things. If you ask someone the question in a way that they know the answer is, I'm supposed to say fine, they're going to tell you fine. So your erections are fine, right? Yeah, they're totally fine, right? It is different than sort of the, again, more generalized women who tend to be more open with each other, have a much more supportive group-like dynamic when they talk about their problems. And some of that is because so many women have a women-specific doctor early in life who is paying attention to these things. They're talking about it when they're 16, 18, 25. They know these things are happening with babies, after babies. They're things that need to look out for. But like a doctor of mine in training once said is, nobody gets a manual that says, hey, when you're 50, this is when what's going to start happening to you. What we need is a guidebook. And so when we see patients, these are the things, at least male patients, that we like to talk about, is make sure we touch on the things that are coming up and what things patients can do to prevent them, or what they can do to intervene early, and if they don't intervene early, what they might expect. And so those things are things like prostate cancer and hypogonadism and erectile dysfunction, things that guys don't like to talk about. And of course, urinary symptoms, which we're going to talk about today. Men's health is so intertwined. If you've seen any of my notes, you'll see that if I see a guy for elevated PSA, I always talk to him about their urinary symptoms, because you sort of can't talk about prostate cancer without talking about BPH. And similarly, if you're talking about prostate cancer and you're talking about potential modalities for treatment, you can't talk about those without talking about their erections, because they may be impacted. So while we're going to focus on BPH, I just want you to think about, when you're sending patients to us, we're probably going to talk about things with them other than their BPH. I'll try to keep this somewhat humorous. Try not to overstretch a little bit. I may walk over the line, so apologize if that happened. But I think this is it's a good sort of silly thing, but it also makes a lot of sense. And I think a lot of our patients really undersell how bothersome some of these, what we would otherwise consider trivial symptoms can be. Not only do we have issues trying to get started, but we also have things like post-void dribble. And that's so frustrating for these patients. They lose just enough urine to feel it in their pants. And no matter how much they try to avoid that, they sort of get beat by it. And it's really maddening, because they may not have any other problems. And so, what we try to do is look at their symptoms, and just like so many things we do, is have this dialogue and say, hey, what's the most bothersome thing for you? And are there anything else that might be dangerous to you? And if not, let's just focus on trying to fix that one problem. So this is the prostate. You guys all know this. Here's the bladder up here. I'm sorry, the dot is small. And then, the urethra channel goes right through the middle of the prostate. And the prostate's function is multifold. It is both a producer of the majority of the seminal fluid. It's also the storage depot where that semen sits prior to orgasm. And at orgasm, after emitting the semen into the urethra, the prostate actually squeezes and clenches shut, so that when muscles squeeze around the urethra here to expel the semen in an antegrade fashion, it doesn't go retrograde. And so I talk to patients, I say, hey, those little yogurt tubes that your kids or your grandkids eat, and you cut off the edge for them, or those freeze pops, and you push in the middle, and it comes at the end. If you cut the edge off both ends, stuff's going to go out both sides. And the prostate is squeezing so that it's only a one-sided yogurt tube. It is sort of roughly walnut size. I don't know, patients are really interested in what size it is. And it is a weird organ. It's one of these bizarre, non-evolutionarily affected organs, which grows our whole life. And that's sort of mostly true. The prostate growth is triggered by the testosterone surge during adolescence. that creates this sexually active organ that is participating in reproduction. As we get older, our testosterone levels drop, but they don't drop back down to when we were 8 years old. There's enough testosterone level there to promote ongoing prostate cell division and growth. And so BPH, of course, is benign prostatic hyperplasia. It's a non-cancerous growth of the prostate. And as long as there isn't nearly severe hypogonadal levels of testosterone, that prostate's going to continue to grow. So it's sort of just a cartoon of that, right? So you start on the left, you've got the normal prostate in pink. Oh, I did something bad. There we go. There's the pink. And here, over here on the other side, we have sort of BPH. It's growing outwardly. It's also growing inwardly, squeezing that channel. It's also starting to mound up under the bladder, and we can see that at times. And this is sort of end-stage BPH, where it's just the resistance to flow has become so much that the urine is backing up. It's a big deal. We hear again and again about the boomers generation. It's a lot of people. BPH affects people as early as their late 40s, but most men, by the time they're in their late 50s or early 60s, are experiencing some form of symptoms. It's a whole lot of people. If you make it to 80, you pretty much have a big proportion of urinary symptoms affected by this. I will see one patient a year, maybe, who is 95, gets up 0 times a night, never had any issues, doesn't dribble. He's like, prostate what? But that's rare. I will see a couple of guys a year who are 48 and starting to have early symptoms. But the majority of guys are in their 50s and 60s. Just like so much in medicine, we're finding that obesity, BMI, metabolic syndrome, all those things, unfortunately, increase the growth rate of BPH. And it matters to men. We sort of alluded to a little bit of this earlier when I was talking about post-void dribbling, but it's really bothersome. You can see that up to 95% of men with just moderate symptoms, and we score that on a score sheet, are pretty unhappy. And if you told them, I can make this better, they would be pretty pumped about that opportunity. About half of men say it interferes with an aspect of their normal life. And it also, interestingly enough, where's the right button, really affects their partner's quality of life. Now, it's something, I've been doing this now for a fair amount of years, training and out in practice. I sort of never thought about this till a couple years ago. I did a UROLIFT for a patient, a pastor actually, and he and I were talking about things, and he had been getting up 3 or 4 times a night. Now he's getting up 0 to 1. He was really happy. And I said, hey, so what's the best part about this? He said, my wife is the best part. And I was like, what do you mean? He's like, she's so happy because she used to get up 4 times a night when I would get up 4 times a night. And he said, I would go back to sleep. It was okay for me, but she couldn't. She had a hard time getting back to sleep. So the biggest deal for him was actually his wife was sleeping better, and she was so much happier. Now, he was happier too, but it was interesting, and it was something I hadn't really paid attention to, but I've heard now that I'm listening for it again and again, that this really affects everybody else in that household. These are just a listing of some of those symptoms. I think you guys are familiar with most of these. But it's interestingly, what you see, especially sort of down at the bottom, is not only is it bothersome, but it's now changing the things that patients are doing, the things that they do to have fun. And a lot of the things that we talk about in men's health are things that have profound contributions to patients' mental health. Yes, this is not suicidal ideation, but we know that these result in patients avoiding things they want to do, and it leads or contributes to depression and an overall sense of isolation. It isolates them from their friends, it isolates them from activities, it isolates them from exercise. All of those things are detrimental to them physically and emotionally, and these are supposed to be sort of the time of their life where they've earned a little bit of a respite. As an aside, we know for men with erectile dysfunction, if we look at them on a depression score, most of those men will actually qualify as mildly depressed, just on a symptom questionnaire. And if we take guys with depression who have coexisting erectile dysfunction and we fix their erections, we actually score better than if we had given them an antidepressant. Men are weird. I'd like to say that we were sort of this postmodern, like, hey, it's an erection, it's like no big deal. But the reality is, genetically, we are programmed so that it is, in essence, and for a lot of men, of sort of what has made us men. And it's hard to separate that out, even if consciously we can say, hey, you know, this isn't cancer, I'm not dying, I do lots of other things. It would be great if this worked, but, you know, sort of okay with it. In reality of it, it does often contribute to some unhappiness. And same thing with BPH. So how do we fix it? Well, the BPH landscape is changing quite rapidly. Historically, it moved very slowly. At the beginning, we just sort of kept an eye on it, and then patients got catheters. That's all we had. And then the next step we had was surgical therapy. And I'm sure all of you are familiar with TURP and simple prostatectomy. And we talk about the prostate a lot as like a fruit or an orange. And we say, hey, simple prostatectomy is like keeping the rind of the fruit and taking out the pulp, or taking out the fruit part. And we do that because the prostate abuts the urinary sphincter and the nerves for erection. So taking out the whole prostate puts those at risk. Much less risk if we just sort of take out the fruit. And that's the idea behind both simple prostatectomy and TURP. And then we got medications. And medications has now been around for a long time. I have some friends who actually trained whose fathers were urologists, and they told me that when their dads were practicing and these medications came on the market, they thought their jobs were over because all they had was TURP, and lots of guys have BPH. TURP was like a mainstay of what they did every day. When they got these medications, they thought, hey, no more TURPs. This field is going to fizzle. In reality, medications are helpful, particularly early on in BPH, but as BPH progresses, they often become less helpful. And just like every other medication that there's ever been an article about compliance, most men are not very good about taking their medications every day for 15 years. We know that dropout rate is 50% or greater for every other medication that's been tested, and medications for BPH are no different. Similar to TURP and prostatectomy, about 10 plus years ago, we started getting laser treatment. This is essentially digging a hole with a different instrument instead of using an electrode. Like monopolar or a bipolar electrocautery to do the resection of the prostate. Now we use a laser. The laser companies would like us to believe that these are head and shoulders better than TURP. It's safer, blah, blah, blah. In reality, it's just like digging a hole. You can dig it with a shovel. You can dig it with a pickaxe. You can dig it with a backhoe. At the end of the day, you have a hole and all the potential things that come with that hole. And more recently, we now have two other therapies on the market, UROLIFT and Resume. And we're going to talk about sort of these more in detail. And then upcoming is AQUABEAM. So we'll sort of talk about these things. So which is better? Patients say this all the time. What's better? Which one is better? I want to know which one's better. We live in the internet age. We all Google search everything. What's the best mid-sized car to buy? I just want an answer. Well, it depends on what you're looking for, and it depends on the outcomes. It depends on the efficacy. So we look at things like their symptom score, which is the IPSS, how well they're emptying their post-void residual, and what's going to happen with longevity. Is this going to prevent progression? We look at safety, and I think historically, as urologists, we have done a poor job about incorporating safety into all of these things. We look at cost, and this is also sort of new in the surgical armamentarium. Hey, we have to know how much this costs our patient. Well, I'm just a doctor. Well, I'm not an insurance person, but the reality is medicine is really expensive. Patients are shouldering increasing amounts of that burden, and they want to know how much this is going to cost them. And so it's important for us to know those figures, or at least have an idea as well. And then, how long is it going to take me to heal? And that's part of cost too, and part of safety. If this is going to be 8 weeks where I'm out of work, even though this is bothersome, I might not have 8 weeks of vacation time built into my schedule. I can't afford that. I have to work. I may be the only person working in my family. So return to convalescence is really important. So if we sort of try to go through these different therapeutic options under that umbrella, we'll sort of evaluate things. Alpha blockers are Flomax, which is sort of the poster child. These, we say to patients, these relax the muscles of the prostate. If we go back to the original discussion of prostate function, the muscles that cause the prostate to clench or squeeze or contract during orgasm, these medications inhibit that contraction. And so just like if you have a stroke patient who loses the tone on their face and it droops, at baseline, if you get rid of the tone of that muscular stroma in the prostate, what you get is a little popping open of the prostate and decreased resistance to flow. There are sexual side effects, most notably that patients are going to have retrograde ejaculation. When they orgasm, you're cutting off both ends of the yogurt tube, and so semen is going to go both ways. Because the prostate is situated high up, close to where that rhythmic contraction of the periurethral muscles is happening, there's very little resistance to flow because that's a short tube. The rest of the urethra is a long tube, and resistance to flow is related to the length of a tube. And so most of the semen ends to go retrograde. And so patients will often complain of a dry orgasm. Again, I am surprised, maybe I shouldn't be, I'm surprised at how bothersome this is for patients. Because when we think about it in our doctor's sort of hat, like, well, you know, you're 60, you're not trying to get anyone pregnant anymore, what's the big deal? This is, you know, orgasm is something personal for patients. It's something they're used to having happen in a precise series of events, and changing that, it is bothersome to patients. Sometimes it's really bothersome to patients. Sometimes patients don't care, but we now have to make sure we talk about those things and let patients know that this might be really bothersome for you, and if it's bothersome for you, it's bothersome for me. I don't get to just sort of say, well, what's the big deal? I can cause some nasal congestion. It is something that if you stop taking it, it's going to stop working, and it doesn't prevent BPH progression. On average, this will reduce the symptom score, the IPSS, by about 3 points. It turns out that 3 points is something that is about how much you need for patients to notice a difference, so it sort of makes sense. Overall, that scale is 35 points, so it's 7 different domains, like how much, out of 1 to 5, do you have a weak stream? How often do you get up at night? These are sort of the questions. Each one is a 5-point scale, and 7 times 5 is, of course, 35. So if you have pretty severe symptoms, Flomax is probably not going to move you dramatically down. So if you have somebody who's got an IPSS of 28 and you put them on Flomax, they may come back and say, I'm better. And if we just stop listening and say, I'm better, and you're like, okay, great, on to the next thing, we may not be able to realize that I'm better, but not that much better. And so we monitor that to sort of see where they're at. Because again, if we ask them with a leading question, hey, are you any better? And if they say yes, we just sort of move on to the next thing. They're going to feel like, hey, better, this is all I'm going to get. I got better, this is what I'm expected. I said the right answer, we're moving along. But if we say, hey, I see that you're better a little bit, your symptom score is better, you're telling me you're better, but are we winning the game? Is this still bothersome for you? You know, if we could make it better than it is even today on medication, would that be a helpful thing for you? Proscar, we also have dutasteride or Avodart. These are 5-alpha reductase inhibitors. Their mechanism of action is to limit the enzyme activity of 5-alpha reductase in the prostate and also elsewhere in the body. And what they do is they prevent the conversion from testosterone to dihydrotestosterone, or DHT. And DHT is realistically the fuel for prostate growth. So preventing that DHT results in some atrophy of the gland. And the value of Proscar is really to prevent progression. It does have some mild improvement in symptoms, and mostly that improvement is best when coupled with Flomax. It's sort of a 1 + 1 = 3 sort of a deal. But overall, it's not a big change in symptoms. It's mostly used to prevent progression, and the studies only show that it prevents progression in patients who are already at a fairly large size prostate. Small prostates, which are really bothersome, don't tend to really respond well to Flomax. And I know the digital rectal exam is not the ideal study to show us what the size of the prostate is, but it does give us an inkling. If they've got a pretty small prostate, Proscar or Avidote are probably not going to improve things dramatically. One thing I want to talk about medications is that in the last 5 years for Proscar, in the last 2 years for alpha blockers, we have seen some really important and eye-opening studies suggest that these medications are not innocuous other than their sort of transient side effects, that they may have some really important long-term unfixable side effects. And so with Flomax, we've seen some data that suggests that patients with long-term alpha blocker use, Flomax was the drug that they looked at most commonly because it's the most commonly prescribed, that these patients have an increased risk of future dementia. And that's a really big deal. And we talk about it with our patients in the same way I talk about it today. I say, hey, this is a really hard study to prove. You think about all the variables throughout life that things may happen that produce one person to have dementia, one person not, and then isolating that down to the use of one medication and showing that consistently across thousands of people is a really challenging study to do. We may never get the real answer, whether this is right or wrong. In general, when we grade this evidence, it's pretty poor. So what's the risk? The risk is if it really does contribute to dementia, and we keep you on this for 5 or 10 years, you may get dementia and all the attendant complications with that. If we're wrong, the only downside is we have to take you off your Flomax, which is crappy, but it's only crappy if we don't have another option. I think now we're uniquely situated that we do have some really good options other than Flomax. So I think it's important to have these discussions with patients, and I think because patients are pretty scared, as I would be, about maybe having dementia, because most of us have somebody we know who's had it, that most of them will say, that's great, I don't want to be on this long term. And then the question is, well, what's long term? I don't know, probably a year or so, not a big deal, maybe 2 or 3, probably still not a big deal, but maybe 10 or 20, big deal. And for 5-alpha reductase inhibitors, we have always seen the potential for a sort of hypogonadal state with some of these medications. We always said, well, you know, if you start to experience some erectile problems or some low libido problems, just stop it and all that stuff will go away. Well, it turns out that a percentage of those patients, it doesn't go away. And we used to say, oh, well, it's just because you're also diabetic or you're also overweight or you have high cholesterol. That's how it is. But in reality, after we've been drilling down on this for a couple of years, it turns out that there really are patients who have permanent side effects just from these medications. So if I have a patient who's sexually active, I'm not putting them on this medication. Same reason. It might help you a little bit and it might prevent progression. The alternative, you know, what do we have that's not this risk? Is it worth it to try that other alternative? Is it worth it to stay on this medication? So I'm finding that we are using a lot fewer of these medications, and sort of those older urologists who thought life was over because those medications were around are now finding themselves very busy again, because the data we had at the time was data on 1 or 2 years of usage. And just like metformin, the controversies, the statins, the controversies, we're finding out now that we've had patients on these drugs for 10 or 20 years that maybe systemic intervention is risky. These are things that have chemical receptors all throughout our bodies, and limiting those chemical receptors for 20 years may have big consequences. TERP, just to sort of move through this quickly, this is something that, again, probably most of you are familiar with. In this picture, the orange up here is the prostate. This is the urinary sphincter here. For anatomical notation, this is where the nerves that control erections run. They're sort of pasted to the back and side of the prostate there. TERP, and most patients will talk to me if they've known someone who has TERP. They'll say, oh, is that the roto-rooter? And I'll say, yeah. And that's really the best description for this. It is a roto-rooter. What we're doing is systematically sort of shaving out layer by layer in a larger channel circumferentially throughout the prostate. And this is what it would look like ideally when we're all done. In this picture, here's the prostate. Again, here's the sphincter, and here's the bladder. Here's a pre-op picture. This is sort of what we call the curtains of the prostate coming in from either side, the urethral channel in the middle. This is after it was done, and this is sort of healed up a few months later. You can see a pretty dramatic effect. This is a laser, but essentially, again, you're digging a hole. So when I talk with patients about TURP, I talk to them about anything that digs a hole. Simple prostatectomy, TURP, laser, because they're all pretty similar. In general, they're fairly expensive. They're fairly expensive because it requires you to take a patient to the operating room. So the patient's paying their copay for an anesthesiologist, for that operating room, often for an overnight stay. There are complications. There's a pretty high risk of sexual dysfunction, particularly ejaculatory dysfunction, because you're destroying so much of that fibromuscular stroma that they can't close that prostatic urethra during orgasm. So I tell them that if they've been on Flomex, I say, you know that ejaculatory dysfunction you had on Flomex? Yeah. Okay, well, that's going to be permanent. You got to know that up front. So we talk about that a lot, because it's very rare that men are going to have forceful antegrade ejaculations after that. There is erectile dysfunction with this. Again, in the past, as urologists, we sort of blew it off and said, bah, that's just your progression. You're just remembering this because the way our brains work as humans, we sort of hone in on recent events that are different or out of our abnormal activities. And we say, well, you know, I guess my erections are worse, and I did have that TURP 3 or 4 months ago. Maybe that was related. Sort of like if you throw up, you're like, I had tacos today. I don't usually have tacos. Maybe it was a taco. And so we have a lot of bias in the way our brains work. But in reality, when we started to follow this more closely, there is definitely a subset of patients who have worsened erections afterwards. And we think that that's related to the distribution or the dissipation of the energy we use, as, you know, that just like heat, that energy doesn't dissipate just on contact. The closer you get to the outside of the prostate, and the more that energy sort of dissipates through tissue, the greater the risk that you cause some energy injury to those erectile nerves, those cavernosal nerves. So it is possible. Again, so if I have a guy who's sexually active, we're going to have a lot of discussions about that risk-benefit alternative prior to surgery. And then there are 2 other really important risks with TURP. One is sphincter injury, and similar to the dissipation with erectile dysfunction, we think that that's dissipation here down to the sphincter. In reality, the sphincter is sort of more like a hand, the prostate inside it. It sort of grows upward over the apex of the prostate. It's got this bundle that's sort of a larger piece of it that's outside the prostate, but it depends on how large that sphincter is, and that's something that's genetically determined. Some people have really long sphincter complexes. Some people have really short ones, and they can't afford much injury. Some people have existing diabetic neuropathy, and their sphincter's not that good to begin with, and part of the reason they're dry is they've got this really big prostate providing a cork and sort of a crutch for their continence. And now if you take that cork away, it may unmask some existing sphincter dysfunction. We see this a lot with guys with Parkinson's disease, for example. So they have to know that there's a 1% chance that they may be unable to control their leakage. And then there also is a risk of a stricture, and strictures happen in 5 to 10% of patients. As a reconstructive urologist, just like everybody, we sort of focus in on what we know. Stricture of all these things may be the thing that I get most worried about, because it's now requiring another surgery to fix a problem with a surgery. And that surgery is not a walk in the park. They may need a urethral dilation, which, you know, when you tell a patient, well, what are you going to do? Well, we're going to put bigger and bigger sticks up your penis until we make a bigger hole. That's what we're doing. And if that doesn't work, we have to do a urethroplasty. And that's a really big operation. That's a 4-hour operation. It's a catheter afterwards for 2 to 3 hours. We may need to take a piece of their cheek lining to fix it. That's a big deal, all to fix a problem that we had with their TURP. So a great surgery from the surgeon's perspective, And I'm sure your journals say the same thing. We should have shared decision-making. Before shared decision-making, we were paternalistic surgeons. We would say, TURP is the best. Why wouldn't you get a TURP? We look at our data, flow, post-void residual, and we said, listen, nothing comes close to this TURP. Why would you want to do this? A TURP is the best. Let's do TURP. That's sort of our way of it. When we talk to patients, we say, TURP is the best, but it's only the best if you look at flow and post-void residual volume. It is not the best when it comes to cost. It's not the best when it comes to a safety profile, but it is the best for these other things. So maybe it's the best for you, but maybe it's not. It does have good durability. None of these things are perfect because that prostate keeps growing, and it does improve that symptom score by about 10 to 15 points, closer to 15. Recovery is not quick. It's about 4 to 6 weeks, and during that recovery, most men will have pretty severe urgency and frequency. You tell them you're not leaking. You may leak for a period because you can't make it to the bathroom in time. If they have to go back to work in a week and sit at their job as an attorney, they may not want a TURP because they may not be okay with potentially peeing their pants in their business suit. It's a good way to talk to patients about it. I tell them, hey, if you fell on your bike and you ripped that skin off your thigh, boy, that's going to take a while to heal. That skin's got to grow back in. It's just a raw surface. Nobody's suturing that back together. That's what we have in here. We have a raw surface, and it's got to re-endothelialize. It's got to re-skin over on the inside before you start to really experience the benefit. And that may take a while. I tell patients, you should print out a picture of me, take it home, get a dartboard, and throw darts at it and be angry for the first couple of weeks. And when I see you, all I'm going to do is tell you whatever your complaint is, it's going to be okay. Because they're pretty miserable for the first couple of weeks. This is sort of all urologists remember this picture. This is sort of what we did as residents a lot. This is a patient who's post-op TURP or laser. They've got a catheter here, drained to a drainage bag. It's called a three-way catheter. I'm sure you guys are familiar with this. There's a balloon port, there's a gravity drainage port, and there's an irrigation port. So they've got a bag flowing sterile water or saline into the bladder, getting rid of the blood clots or blood so it doesn't clot and cork off the catheter and draining out in this bag. So this is sort of what patients can expect to do overnight and sometimes for a couple of nights. So sort of not super glorious. UROLIFT is now 6 and change years old, and UROLIFT is the first of all the BPH treatments surgically to really be a different, truly different modality. And at risk of sounding like a salesman, and we talk about this with patients too, this is a really good operation. It's very thoughtfully designed. There's not a lot of drawbacks to UROLIFT. It's interesting. The guys who invented this are very smart guys. They're guys from California. They have invented several different medical devices. They invented the balloon septoplasty. They invented most recently the tubeless nursing bra. Some of the guys helped work on the original pacemaker stuff. They are smart guys. And what they do is they look around the medical landscape and they say, hey, what's a problem that's, they're interested in making money. What's a problem that's really common that what we're doing now is not that good? And a lot of what comes out of their own personal family life. So one of the guys' dad needed a TURP, and he was telling his son about this, and he's like, what? You're going to have this? This is our option? This is terrible. And so he said, hey, guys, started looking at this BPH thing's really common. This TURP stuff doesn't seem that great. What can we do? How can we figure out a better way to do this, a better mousetrap? And so they tell the story, they were in the cadaver lab, and one of the guys was just sort of squeezing the prostate, and then it hit him. He said, hey, guys, this prostate tissue is compressible. You can squish it. How can we squish it to open up this channel? And so that's really what UROLIFT is. You're pulling the curtains open. That's the picture here. You're pulling this and squishing it up against itself and squishing this up against itself, and you're getting this nice channel right down the center. And the way it works is these little implants hold that prostate in that new unobstructed position. All right, so this is sort of post. What you can see here is you can sort of get the idea that something is drawing the tissue laterally, and that's the implant. It's done in the office. It can be done in the operating room. It takes me about 10 to 20 minutes to do the procedure. Recovery is about a week to 10 days of urgency and frequency above baseline, so there is some of that. It's cheaper, again, if they're avoiding the operating room. The complication rate is dramatically improved. And so I think, to me, that's the biggest thing about it that I like. It is not having any risk of stricture, no risk of permanent incontinence, no sexual dysfunction risk. It's pretty good. It's not as good, from the doctor's standpoint, it's not as good as TURP. It's not quite as good at improving their symptoms. It's not as effective when we get guys who come in and they're in total retention from BPH. A lot of times those guys are too far gone to benefit from UROLIFT, although sometimes we do see some benefit. But when I'm talking to a patient and I put on my doctor hat, I tell them, listen, TURP is the gold standard. It is the best at getting your symptoms down, at getting your flow rate up. But if I put on a person hat, this is what my dad had in Michigan. This is what my father-in-law had in Michigan. So I didn't want him on Flomax. So we have some dementia that runs in both of our families. And I didn't want them to have any of those dramatic complications. And the nice thing is, if UROLIFT doesn't work, they can always have TURP later. So sort of the tagline is, it's cheaper, it ain't gonna jack you up, and we can always do TURP if it's not good enough. And so I think patients really like that. They really like safety. And I am surprised and not surprised at how bad I and my colleagues as urologists have done with this in the past. And when I think about what I would want for my own health care, I want something that's probably gonna help me, but above all, I don't want something that's gonna make me worse. And I think that's the great thing about UROLIFT. It's not gonna make patients worse. It's likely gonna help them. It's likely gonna help them a lot, about 2 to 4 times as good as their medications. It's gonna get them off their medications at worst. It's gonna get off their Flomax, but it's probably not gonna make them any worse. The question is, how long is it gonna last? Well, it's been FDA approved for 6 years, and the data we have shows that if they get benefit, that benefit for most patients is still going strong at 6 years. But we don't know where that's gonna end. We also don't know what is gonna happen to those patients at 8 years. Will we be able to salvage them with another implant here or there, wherever that growth has been? Or is it something where we're gonna need to do a TURP? We don't know that yet. And this is Rezum. Rezum is sort of the other sort of newish guy on the block. It's new and old. So water vapor or steam therapy has been around for prostate treatment in the past. It's sort of a different way of digging a hole in part. But the nice thing about it is it can be done in the office. So it's another office-based, or what we call a MIST, minimally invasive surgical treatment. It's a MIST therapy for BPH. There are a couple of guys in the area who do this and do this well. I haven't incorporated it into my practice because when I look at it, I don't see a big place for it in my practice. So it's expensive, and even though I can do it in the office, it's painful. I mean, you think about it, do you want to be awake while your prostate gets steamed? I got a little steamer to make my shirts look nice, and I actually get my finger in there, it hurts. It hurts quickly and badly. This is really uncomfortable for patients. They don't like it. Afterwards, this is my favorite, the ablated tissue is then reabsorbed by the body. No, what they're getting is sloughing of dead, vaporized tissue over the course of several weeks until that hole is bigger. All right? They have suggested originally that it doesn't have any sexual complications. There's recent data that suggested that's not true. They suggested that there's no stricture. That's also been suggested, again, by data. That's not true. There's no stress incontinence. There are fewer cases of stress incontinence than TURP, but in general, not completely true, although mostly true. It is effective. It's about as effective as UROLIFT, not as good as TURP. Its durability has been about 3 years, but the recovery is pretty long. It's 4 to 8 weeks, and the catheter is about 3 to 7 days. And so for me in my practice, if a guy needs a Rezum, he just needs a TURP. There's not a lot of safety benefit. There's not a ton of cost savings, and they're going to have a faster convalescence with TURP. The only patient for me that I would do a resume on is somebody who was so sick that they couldn't go to the OR but needed a TURP. And in my practice, that's maybe one patient a year. So I don't see a lot of role for resume. There are other guys who do it well in town. I think they're great docs. I think they're great surgeons. But when I look at it from my perspective and think about how does this fit with patients, how does this fit in my practice, I just don't see a big spot for it. This is sort of some of that data showing a busy slide, which I hate when these are up here when other people put them, so I don't know why I put it in my own presentation. But this is just showing that also what we see with a resume is that we really only see benefits, the square line, in patients with pretty severe lower urinary tract symptoms or LUTs. The other guys with moderate or mild LUTs, they don't see a big improvement. They see an initial blip, but they start to get back to their baseline. And I think that's the issue is resume the way it works is probably helpful in destroying tissue, enough tissue that when patients are really bothered by things, they notice a big change. But when guys have relatively mild or moderate symptoms, it just doesn't destroy enough tissue to move the bar, but they pay for all the consequences. This is coming down the pike. It's AQUABEAM. I don't know. It's been FDA approved. I don't know where the insurance market will move on this. This is a pretty cool thing from a geeky urology surgeon standpoint, but I don't know where it's going to fit in. The way it works is it's done in the operating room. You put a transrectal ultrasound probe in the rectum, and using that transrectal ultrasound, you make this sort of dotted line. You outline it where you want the AQUABEAM to work. Then you put this cystoscope in with the AQUABEAM, set it on auto, and step away. And then the robot, it's a robotic device, the robotic computer device uses this super-powered high-pressure blast of water. It's power washing your prostate away, essentially. And it goes back and forth really fast, and it ablates the tissue to the depth and location that you told it to. The downside of it is it has to be done in the OR. It's going to be expensive because it's new. And what you're going to end up with is a TURP-like cavity. It's going to be fast. It's a little bit faster than TURP, probably half the OR time. But at the end of the day, we'll have to see what it looks like on safety. And right now, the safety is suggesting that's probably a little more dangerous than TURP. We're seeing a couple of cases of blood transfusion requirement, which we usually just don't see with TURP. So this is coming, maybe, but I don't really know if it's got a big place in our sort of commonsensical armamentarium for BPH. There's still a stricture rate, there's still an incontinence rate, there's a big bleeding rate. The IPSS change was improved, statistically significant, not inferior to TURP, but maybe not better. So, in summary, what we have is we've got issues that impact a lot of guys. They impact them in meaningful ways. The existing stuff that we have had historically has been helpful. Medications are good, but now we've got data that suggests maybe they're more risky than we thought. While they're helpful, they don't usually prevent progression other than pro-scar, and they don't dramatically improve symptoms, but they usually do move the needle in an appreciable way. We've got TURP, and TURP has been long-standing and sort of withstood the test of time. It's a good surgery. It is not a risk-free surgery. When everything goes great and patients have the time to recovery and they're not interested in sexual function, TURP is a great surgery. It really is incredible. But there's always that risk. We have UROLIFT, not as good as TURP in terms of objective outcomes other than safety, but dramatically safer, probably cheaper. We can do it in the office, faster time to convalescence, doesn't preclude TURP. We've got Resume, which does, again, a pretty good job of improving the symptoms, at least in men with pretty severe symptoms. It can be done on anybody.
Code gray, 5G39. Code gray, 5G39.
But it does have some safety drawbacks. And then we've got AQUABEAM coming, and we'll see. In general, the things that I think are important to talk to your patients about is talk about their symptoms if they're bothersome. I think it's very reasonable to start people on Flomax. I think it's helpful because if they get better on Flomax, then you know that their prostate is at least the majority player in this. It's important to remember that lower urinary tract symptoms in men are not just prostate. They can have urethral strictures to start out with. They can have overactive bladder. They can have an underactive bladder, sort of an atonic bladder or something on that spectrum. But if they get better on Flomax, then their prostate is probably a big part of it, and that's most men. But that long-term Flomax maybe isn't a good thing for patients. And if we ask our patients in the right way, probably if they've been on Flomax for a couple of years, they're not doing as well as we think they are. It's not a set it and forget it. We've got other options, and we've got other options that are actually pretty low risk for the patient, well covered by insurance here in Oregon, and pretty safe. What questions can I answer for you guys? Sir?
Why do you create such a big cavity with stirrup?
That's a great question. We create it. What's that? Oh, why do we create such a big cavity? We create it because that's the way we've always done it. We do what's called a channel TURP. Sometimes if you just want to, do a small TURP and just get a guy, sort of move the bar, but they're high risk for incontinence, someone with Parkinson's, for example, and you really just want to try to reduce it a little bit. We've done it a large channel in the past because we wanted to prevent them from having to come back. And that's sort of the way it was done. If we made a small channel and just did channel TURPs, would that decrease the complication rate? That's a good question. That would be a good study to look at to see what their efficacy would be in terms of their symptom score and PVR, as well as their side effect profile. It's a hard thing to sort of know what enough is, the way that the tissue behaves in the OR, but it's something of interest, and I understand what you're saying, yeah. Sir?
I'm just curious about the UROLIFT, the mechanics. What exactly is the prosthesis made of that you're using? Does it have contact with the urine?
Yeah.
Being an infectious disease, I worry about foreign body infections.
We do too. There's a lot of inappropriate hand gestures here, so forgive me, all right? So imagine this is the urethra and my hand is the prostate. The UROLIFT is put in, a camera goes through, and then the device sends a small little curved needle through the middle of the meat of the prostate, the parenchyma, and it passes it to outside the capsule. Packaged in that hollow needle, when it retracts, is the suture, which is non-absorbable nylon suture, and a little end piece that's sort of packaged alongside that suture. So when that needle retracts, it flips open like a T, and as you sort of pull back on the device, it's like hooking a fish, sort of grabs on the outside of the capsule. And then you've got this sort of, imagine it's like a fishing rod. You've got this fish, and it sutures on tension. That's like the line. And then the second piece is sort of swedged on. It's like a clothespin, so it sort of gets rammed onto the taut suture like this, and then a blade cuts the suture. And so now you've got this sort of custom-made implant for that specific space. We do it all the while we're physically compressing the prostate out of the way with the beak of the scope. So that's how it's done. In reality, that portion of the implant that's theoretically in contact with the urine, it actually pulls it, and if you look back at that picture, you can sort of get an idea of that. It sort of pulls, there it is. It pulls into the tissue here. And actually, if you go back in and look a couple weeks later, it actually re-endothelializes over that. It punches in so much. Imagine if you took a really obese person or even like a pillow, and you pushed in, you wouldn't see your fingertip, even though your fingertip is doing some mechanical force. And that's sort of what happens. And so there hasn't been any problems with encrustation of that urethral end piece. The problem does come, the risk, is that if you have a prostate like, where's that one? This one. And you can see how it's growing upwards a little bit. If you send that helical needle out from here, it may end up here, outside the prostate, but inside the bladder. And that end piece then is exposed to the urine and can encrust So when we see guys who had UROLIFT, they're coming back with urgency frequency, we'll put a scope in and look back, and if sometimes we will see some encrustation of that end piece, and then we can either just laser that off and hope it doesn't come back, or we can just resect using like a resectoscope, a TURP, just sort of TURP off that little lop of piece of prostate in that zone. But when we see big prostates, that's something we are wary of. It's sort of one of the skill set advantages to doing a lot of these, but it happens. And that's a very good question. Sir?
Can you discuss in some way the efficacy of saw palmetto?
Yeah, saw palmetto. So the question is, what's the efficacy of saw palmetto? So saw palmetto is actually one of the, we have a lot of patients who come in on a lot of supplements. It's one of the few supplements where we have evidence-based, randomized, controlled data versus placebo, and it doesn't show any improvement in either BPH symptoms or progression. So it's no better than placebo. Sir?
What about low-dose finasteride, 1 milligram a day used for alopecia long-term? Is there any evidence of an effect, positive or not?
We do have data now that we sort of started uncovering these sexual dysfunction, hypogonadism, long-term risks with finasteride 5 milligrams. Dermatologists looked into or started looking into the 1 milligram dose used for baldness and hair regrowth. And they do see that same percentage roughly of side effects in that population. What we don't have, so we know it's the same risk. We don't have efficacy data for men on it at 1 milligrams in terms of their lower urinary tract symptom results. Let's go here and then here.
If I like either spongy organ,
Yeah.
my sense is that you're going to push, the pressure's going to push it north and south.
Yeah, it's going to sort of be like you push a pillow and it,
Right.
yeah. We see that sometimes, and we have all sorts of anecdotal terms, pillow prostate, whatever. But reality is, if that happens, if you sort of push here and these parts pooch out, you can sort of push those back in with a second or third implant, depending. But we sort of look at the prostate, and after you do enough of these, sometimes you'll be like, this prostate, I don't know. It might be a little, it's not the perfect prostate. You'll tell the guy, I don't know. We could do a UROLIFT here. I have some reservations that it may not completely work for you. We can try it. Depends on what sort of your comfort level is with TURP. And, in my experience, most of the guys are like, if they want UROLIFT because of the safety side effect, they're willing to take a risk on a procedure that's not going to be completely efficacious. And then they'll say, well, if I try this and it doesn't work, at least I feel like I tried the low risk option, and we can do TURP later. But it does happen like that.
Can you tell if you have a spongy prostate versus a firm prostate?
You can sort of get some inklings, and we think we're so smart. We talk about it ad nauseum in sort of our center of excellence, UROLIFT community, and people sort of have all these ideas about what they see is going to make that. In reality, probably better than people who've not done it before, but it's never perfect. Yes, sir. GnRH agonists have never been tried directly for their use in lower urinary tract symptoms, and it's because their safety profile is such, you would have a hypogonad state and all the attendant complications that come with that, loss of bone density, increased risk of diabetes and cardiac disease, libido changes, energy changes, sleep changes. So it's a pretty high-risk medication for something that we have lower risk intervention opportunities. But when we have guys who have prostate cancer on GnRH, they tend to have a loss of progression of their symptoms, but they don't typically have a dramatic improvement in their symptoms because just like finasteride, you don't see so much atrophy that their prostate sort of goes away completely. Sir?
One of my friends from Palm Springs talks about some of his friends who are getting a European machine surgery with ultrasound for same problem. Is that good, bad?
Yeah, we have. So in Europe, they have a couple of different options that we don't have here, and it depends somewhat on what they're using it for. So there's low-intensity shockwave lithotripsy that has gained, and this is just like ESWL for kidney stones, but much smaller sort of sound wave booms. And the thought process is, it's used actually a lot for erectile dysfunction, is that you're sort of hitting it in a way that it irritates and creates signaling for angiogenesis, and that may restore blood flow for the cavernosal tissue. At AUA this year, there was a couple of presentations, and we just don't have enough data to show that it really works reliably, but it may be coming. I haven't seen, we call it LISWIT, low-intensity shockwave treatment. I haven't seen LISWIT used reliably for BPH. We do see focal ultrasound being used for prostate cancer. We've seen that for several years now. The data for it, and they sort of turn up the frequency, and essentially the sound waves vibrate so quickly that they cause heat and destruction of the tissue. And we know that it works well for low-risk prostate cancer. Prostate cancer tends to be multifocal, especially when it's moderate or severe in its aggressiveness pattern, Gleason 7, 8 patterns or greater. And so focal therapy is not very helpful for that. And the big push for sort of zonal treatment or dominant lesion treatment, partial prostatectomy, if you will, with ultrasound came while active surveillance was sort of still in its nascent years. And now that active surveillance is sort of the predominantly used intervention for low-risk prostate cancer, what's riskier, doing nothing or doing something? And so I don't see a lot of role. And John Gunzelman's our big prostate cancer guy. John doesn't either. These sort of focal therapies for prostate cancer, they are very good for low-risk prostate cancer, but so is doing nothing. And so is probably zipping up your zipper 30 times a day. There's not, everything will do well because those patients de facto do well. I don't know if that's helpful for your question, but I haven't seen a lot for BPH. Sir.
Excuse me. What do you do for patients who have a perfectly good stream that suffer from nocturnal frequency and urgency?
We do a nocturnal avoiding diarrhea, and this is actually a really good question. Nocturia is challenging. It's challenging because maybe they have restless leg and they get up 4 times a night. And if I get up because my 2-year-old or 3-year-old wakes me up in the middle of the night, I'm peeing before I go back to bed because most of us don't like to go to bed with anything in our bladder. And if we wake up enough that we're awake, that we're cognizant that we have something in our bladder, we will go to the bathroom. So it depends on if you're getting up and going to the bathroom or getting up to go to the bathroom. And those are very hard things to tease out. Avoiding diarrhea is helpful, so they record what they drink and the volume of it and the time of day and how much they pee. Let me give them a little cup to measure over a 24-hour period a couple times. And if we start to see, they pee 2 to 4 ounces a couple times a night and they pee 2 to 4 ounces multiple times during the day, well, that's somebody that either isn't emptying well, and we'll know that by their post-void residual, or they're getting an early alarm, they're sort of partially into filling and they're feeling like they have to pee. And that's overactive bladder. So we treat those patients with anticholinergics or Myrbetriq or Botox or Interstim. If it's somebody who has no symptoms, which is pretty common, they have no symptoms during the day, but they only have symptoms during the night, that's somebody who has a sleep disorder. And most of those people will have obstructive sleep apnea. It's really interesting. You'll often see these guys who get up 3 or 4 times a night. And the first question I ask them is, well, when you get up to pee at night, is it like a little squirt? Or is it like a little pee? Or is it like a pee? And they'll say, well, I'm peeing a fair amount. So if you're peeing a fair amount several times a night, either you're drinking a diuretic before you go to bed, or it's polydipsia. You're drinking a gallon of water before you go to bed, or a gallon of something. You have lower extremity edema, and that gets reabsorbed when you get those feet back up, or you have CHF. Or you have obstructive sleep apnea, and that obstructive sleep apnea mediates a atrial natriuretic peptide through the stretching of the heart while the chest cavity is struggling to open up your airway enough to breathe. Because it's a closed box, that negative pressure, it's a big negative pressure when you're trying to breathe, it will pry open the atrium enough that it results in activation of the atrial stretch receptor. And the response of that which under normal circumstances would occur while there was a large load of blood coming back through the IVC, the response of our normal physiologic of that response of that stretch receptor is ANP, a signal to tell the kidneys, hey man, I got too much fluid here. It's all coming back here. It's stretching me out through my IVC return. You got to get rid of all this extra water. But when it happens with sleep apnea, it's an inappropriate activation of that signal, but the same downstream effect occurs, and they have nocturnal polyuria. These guys produce 30 ounces of urine at night and 25 ounces the rest of the day. And those guys need a sleep study and a CPAP. And I'll probably see 3 to 4 patients a month like that.
There's a second question, if you can take it. Do you ever see couples or somebody with, their partner? Do you ever involve them in the decision?
As much as possible. I love it when they come in with their partner. That's the best. Do we ever involve couples or partners? And I think just like everything else, especially with big deal diagnoses, we or patients tend to hear only a fraction of what we're telling them. And it's always good to have another pair of ears listening, especially when we're talking about things like cancer or big deal topics. So yeah, the more the merrier.
Well, thank you, Dr. Boncher.
Thanks, guys. Hey, man, what a great group of